maintenance therapy is one of the things we focused on quite a lot. So we've done extensive drug metabolite profiling over the last, 30 years. And now more recently, we've been able to monitor the amount of maintenance therapy, which is really the 6-mercaptopurine, incorporation into the DNA. So approximately 1 in 6,000 nucleotides are replaced by thioguanine, which lies silently around. From time to time it becomes methylated, then it starts mismatching, you get apoptosis. When we do this monitoring, we find that there's a huge difference among patients. So it's 10-fold difference between those that have the lowest level of DNAGG and those that have the highest level. And this, you could say, metabolite concentration, or this build-up in the DNA, is very strongly associated with the risk of relapse. And that's the case both for the children and for the adults, with exactly the same hazard ratio. So in that context, there's really no difference. Maintenance therapy is critically important across all age groups. However, we've, over the years, taught to be very serious about maintenance therapy. We really titrate the maintenance therapy for the children very vigorously, and the mothers ensure that the children get the drug that we actually prescribe. When we go to the older adolescent group, and even more so for the adult group, we see there are quite many patients that are non-adherent to the therapy. And I think there's a lot of relapses in adult groups that can be prevented by having a better monitoring. So in the current protocol we are starting because it's across 14 countries in Europe, we're currently starting. We have a large randomized trial where we try to increase the efficacy of maintenance therapy by adding another thiopurine, the thioguanine, and we include both children and adults. But in addition, we monitor maintenance therapy metabolites for all 7,000 patients on the protocol. And that will give us a very deep phenotyping on how different age groups handle these drugs, and also to which extent we can link relapses with certain age groups or with certain cytogenetic groups. The only group where we feel that they may not need maintenance therapy is the patients who are MRD negative at the end of induction therapy. And of course, that's only a small fraction of the adult cohort.